last speaker is Lisa Mertens, and she is a nurse practitioner as well as a respiratory therapist, and she works in the sleep clinic at UI Healthcare Iowa River Landing, and she is here to speak on update in diagnostic of obstructive sleep apnea at UIHC and home sleep apnea testing. So please welcome Lisa.
Thanks. Thanks. So am I the last one? What is this?
Yeah, you might have to take that now talk.
Are we good? Can you hear me okay?
You might have to talk loud.
Okay. Now can we hear me okay? Good heavens. How about now? Better?
Try it.
Okay. I'm just going to start talking, and we'll just go with it. Okay, so anyway, thanks for all your patience, considering that this is the very last thing of this conference. And I'd like to say that you saved the best for last, but that might be a bit stretch. So anyway, so many of you I recognize, and it does give me actually a lot of peace to know that there are people out here that I've seen before. So thank you.
Sorry, Lisa.
So Lou and I go way back. She can do this all she likes. Yeah. So.
All right. Try it again.
Okay, now we're going to go with this. Are we good? Okay. So I'm just going to talk loud. Okay, this is not probably going to be an hour unless you really are compelled to ask a lot of questions. As Lou mentioned, I started my career in healthcare as a respiratory therapist. I left for a while to sell drugs, legal kind, and then and I went back to school when I figured out that I wasn't having fun anymore. And then they had people like Greg hanging out, you know. So anyway, as Lou said, I'm a nurse practitioner. I am the clinician that does the follow-up for all of the home sleep apnea tests that we're doing at IRL, and I kind of tend to just follow most OSA in general. So, sorry, I gotta learn how to use the clicker. Okay, so I'll apologize. This slide deck is sort of meant as a general overview for all audiences. I'm sure you're quite aware of what a home sleep apnea test is. But it's rather than doing the polysomnogram, so the whole formal in-lab thing, it's something that patients take home. They do it in their house. They do it for one night in our case. And it lets us, we can diagnose obstructive sleep apnea this way. So why should we test? And this is, like I said, this is not the right audience probably for this slide, but it is something that I share with all patients because even though probably 95% of the time the person who's coming in has really already been diagnosed by the person that's sleeping next to them, and that's why they're there. Insurances don't require or don't take that diagnosis. They got to come in and make it official with us. So if they think that they are going to be treated for obstructive sleep apnea so that their bed partner isn't annoyed by their snoring, it's not very highly motivating, I'm just saying. So like I love my husband dearly, but I wouldn't wear a mask just so he could sleep better, right? So I tell folks all of these things because they need to have sort of the motivation and inspiration to be compliant with treatment. And the most recent information that seems to grab people's attention, for some reason heart attack and stroke doesn't do it for people. But if they may develop Alzheimer's disease, that tends to grab their attention. And so during the sleep phases, I'm sure you're all familiar with sleep architecture, N1, N2, and N3, and then REM. We do that about 6 or 7 times a night. During N3 sleep is when your brain offloads a substance that's been building up all day called beta amyloid. It's normal, everybody makes it from normal brain activity, and it gets flushed away during N3, pretty much that's the only time. So if patients don't get to sleep often enough and get to N3 often enough, or stay there long enough, then their beta amyloid doesn't really have an opportunity to get flushed out. It collects. The other name for Alzheimer's disease, as you know, or one of the names is Lewy plaque dementia or Lewy body dementia, and those plaques are beta amyloid. So we do talk about, if you want to live your best life, get some sleep, because sleep's not just a nice to have, it's a gotta have. Okay, so this is how it works at the university. So right now we only are taking internal referrals. So primary care person says, oh, you probably have obstructive sleep apnea. They order the home test. This is, the second point here is a little, that's not exactly correct. It used to be that if someone wanted a home test, Dr. Dyken would have to approve it before he triage it, because if he felt like they were really serious or there's some other serious things going on besides OSA, he'd have them come back for a full-on lab. So doctor orders it, or primary care person orders it. They come in, they pick up the test. They meet with Scott. I'm sorry, go ahead. Obstructive sleep apnea. Nope, just obstructive sleep apnea. So what we do if we find that they have a large or higher component of central sleep apnea, then if they need some other kind of sleep study to look at a different mode of ventilation rather than PAP, or well, it would be PAP, but instead of just CPAP, it might be ASV or BiPAP or something like that. So does that answer your question? Okay, great. So they return the thing the next morning. The results are interpreted by Dr. Dyken, and then they, in a perfect world, they get back to us in the clinic within 2 weeks for their visit or for their follow-up for their results. So in order to qualify for the home test, they have to have excessive daytime sleepiness. You can't, it's really not a test for, I just feel tired sometimes, or my husband says I snore sometimes. They really have to be tired. They have to have two of the three of the next things. Snoring, somebody has seen them stop breathing, or they wake themselves up choking and gasping, and documented hypertension. This is for the in-home. And not significant comorbidities. So like if we think congestive heart failure, something like that, where this test is just a very simple test. It's just a rule in, as my next slide says, is to rule obstructive sleep apnea in, not rule it out. So they have to have a really high clinical suspicion for OSA, not for other weird sleeping things, talking in your sleep, walking in your sleep, none of that business, just OSA. So, and as I said, if they have to be able to do the test, if they have a lot of dexterity problems where they can't put the little probe on or they don't understand the directions, then they're not a good candidate for it, and they need to be an adult. Okay, so if they have the test, it comes back borderline or it's negative, sometimes, and I will say this because there wasn't proper ordering process going on, so someone says, yeah, you're tired, I have no idea what that's for or why you're tired, so let's just get you a sleep test. More likely than not, they're going to be negative. And then I have to decide, okay, do you have enough symptoms where we should do a sleep test, like formal polysomnogram, or do I send you back to your primary and say, you know, is it their iron, is it their thyroid, is it their something or else? If they are positive, then we order auto-PAP, which is auto-titrating positive airway pressure. You're probably familiar with that. So in the old days, and we still do it too, but one night you spend getting diagnosed in the sleep lab, and either that same night or a second night you come back in and you get titrated. So the technician puts a mask on, turns up the pressure to figure out what pressure it takes to keep your airway open. Well, now the machines do that, so it starts really low at 4 centimeters of water pressure. It just builds and builds and builds until the airway is open, stops, doesn't give them any more pressure than they need, but then that number gets recorded, sends it off to the mothership cloud database thing somewhere, and then we get a couple of months of information, and they come back, and then we change their settings instead of wide open from 4 to 20, something that's closer to kind of where they need to be. And then after that, it's a yearly follow-up visit. So the University of Iowa has opened a durable medical equipment for sleep that's real close by, that's convenient, but we let the patient choose. If they choose, I think, let's see, we've got CarePro, we've got Hammer, Hamilton. We don't have Apnea in town anymore, but in Cedar Rapids or wherever their local place is. So that's their choice. And then they come back, like I said, to see us in a few months. We give them their results. This is what the thing looks like. it's just a finger probe. There's no belt, there's no nasal cannula thing. They do wear a little sticker thing that's attached to their chest. It's supposed to help us with positional, are they on their back or their slide? So, and they wear it for one night, like I said. So the technology, and I'm not a representative of this company, but this is how it generally works. So in the formal sleep lab, you've got EEG going on, you've got the oximeter, you've got belts around their chest and their belly and their all limbs and all that. All this is doing, like I said, is just diagnosing obstructive sleep apnea. That's it. So when someone is either apneic or hypopneic, their CO2 levels rise, sympathetic system kicks in, and there's muscle tone change at the periphery. And that's what this thing is measuring. It's just measuring that sympathetic response. It also doesn't differentiate between hypopnea and apnea, just that something not right happened, and together with the oximeter that's inside. And there, like I said, some actigraphy sort of approximates whether they were awake in sleep, but we don't really hang our hats on that. Is there any question about this part? Okay, so does it work? They've done some studies to see if it's kind of close to a PSG result. It's pretty close. It's about 90% is accurate. So if it's borderline, but they still have clinical symptoms of OSA, but it didn't really meet, the diagnostic criterion wasn't met during this home test, then we'll send them on to the sleep lab. So just for your reference, we all know what these numbers are, but 5 to 15 is mild if your AHI is like that. 5 to 30 is moderate. Anything over 30 is severe. And so I oftentimes, when someone comes in with an AHI of 45, I got to talk them off the ledge. It doesn't mean that you're going to die in your sleep from not breathing, but it does mean you want to get it taken care of. And I've seen AHIs in the 150s. I'm sure you have too. So one thing after a year on the job that I have learned, and you should know this too and make sure you don't make the same mistake, is that you want to be careful of not assuming that everybody who has OSA is an old fat guy, because lots of women in my clinic are this skinny and they have OSA. And we just want to make sure, especially for women, because women, if you tell a doctor that you are tired, they will assume that it's your period, right? Or you're anemic, or your hormonal things going on, and you may in fact have OSA. And so if you're tired for no reason, you have hypertension, you think you might wake yourself up snoring, but maybe your spouse says you do, you really want to rule or really consider obstructive sleep apnea. And in fact, we have a PEDS clinic, a PEDS sleep clinic, and a new physician that's with us. Alex Iannone, you may know her. She did PEDS pulmonary fellowship and a sleep fellowship. They don't get a home test, but kids have OSA too. So, any questions about that? Yes, ma'am.
Do you see that one of the doctors the other day, one of our pulmonologists, was talking about some of the children who they feel need to come in. Do you see a certain population that needs to come in more so to be checked?
For OSA?
Yes.
Well, I'm not a pediatrician, but if a kid is snoring when they're a kid, something is not right.
But do you see, like, I guess he was speaking on the lines of, yeah, like either the autistic children or children with Down syndrome,
Yeah.
or those are the children that they catch them right away and get them on sleep apnea or CPAPs. In the long run, they do so much better, and they
Right.
avoid a lot of their heart issues.
Well, I think it will, first of all, yes, you're right. Kids with Downs, just because of their AP diameter, tend to have a higher incidence, or prevalence, I should say, of OSA. For kids, of course, depending on the age, slapping a mask on is not going to be an option. So most of the time, it's tonsillectomy, adenoidectomy, and then watchful waiting. So, but if, like, for example, well, my daughter is 20 now, but when she was little, she would snore like crazy. She had 4+ tonsils, and she was kind of falling off the growth chart. And so we took her, she had surgery, and then she popped right back up. So you're right, bad sleep does affect people developmentally. I think she's mostly okay now, mentally. I mean, got to consider her parentage, but I haven't needed therapy for her yet, but there's still lots of time. So anyway, yeah. Okay, so I get asked about these machines, these cleaning machines all the time. This is not about home sleep apnea testing, but I'm just going to let you know, if you're in the DME world and you're selling these, or if people ask you, this is my line, and it's just based on my experience this past year. So the SoClean machines and things like them are a box that they drop their mask in. There's a tube with their tubing and everything, and ozone goes through the system to clean the thing. So is it convenient? Yeah, it's probably convenient. In terms of being effective, I've seen the studies, the Petri dishes before the SoClean and after.